Dear colleagues, dear friends, first of all, thank you a lot of thanks for the nice possibility to present this lecture to the students, and I'm very happy to have this possibility. The topic is again skin cancer after bisoprolol furosemide intake, links to drug-related nitrosogenesis and pharmaco-genesis. There is no conflicting interest, and this research did not receive any financial support. We report about an 85-year-old patient who presents with a history of complaints of approximately 2 to 3 years in the form of right shoulder discomfort and the problem involving the lower lid of the left eye. The reason for the examination was to clarify the dignity of the lesions in these areas and determine the further diagnostic and therapeutic approach. Patients' comorbidities include arterial hypertension, chronic cognitive heart failure, high-grade aortic mitral and tricuspid insufficiency, atrial fibrillation, iron deficiency anemia, and idiopathic thrombocytopenia. Accompanying medication includes bisoprolol 5 mg once in the morning and once in the evening, and furosemide 40 mg twice daily, so that this medication with both of them was reported as an ongoing medication in the last 7 years. The dermatological examination revealed the presence of 3 primary cutaneous tumors following the regio infraorbitalis sinistra, regio praesternalis, and regio scapularis dextra. The first lesion found in the regio infraorbitalis sinistra in close proximity to the lower eyelid was exophytic with a centrally located erosive surface, and this was covered with a hemorrhagic crux suspected for nodule of BCC. The second lesion found in the regio praesternalis was pigmented and had irregular shape, suspected clinically and dermoscopically for cutaneous melanoma. And the third lesion was located in the regio scapularis dextra, and it was suspicious for epithelial tumor again, so that according to the patients, all of these 2 types of lesions appeared together and started growing simultaneously 2 to 3 years ago. Here you see the first lesion. It's a very unpleasant lesion because of the location of the tumor. It is located under the under eyelid left. And here you see 2 concomitant tumor formations suspected for BCC from nodular type. Simultaneously, we can see here on the right shoulder an exophytic endophytic tumor formation, which is a big one with erosive surface and bleeding. Parallel to this, on the right photo, you see a dark lesion, presternal links, which is probably suspected here, as you can see, for cutaneous melanoma. Clinically and dermoscopically, there were evidence for irregular net asymmetric lesion with diameter differences in the 4 significant regions, which you know, and at the same time slight elevation and regression zones. So that we have taken the decision for a surgical removal of the 3 formations under local anesthesia. So the first lesion, which was located in the regio praesternalis, was surgical treated with safety surgical margin with no more than 0.5 centimeter according to the AGCC recommendations. So that you can see here the disinfection and then the lidocaine anesthesia, and then you can see the deep resection of the muscle. And we here see the elliptical excision. Then the lesion and the defect was closed with interrupted single stitches. Histology was indicative for superficial splenic melanoma, and staging was 1B, 2A, and 0M0. And of course, we have plantar excision and sentinel lymph node, but the patient after that has received some cardiac problems, so that it was not possible to perform a general anesthesia, and we have taken the decision to recommend and perform a re-excision without a sentinel lymph node, and then he has to register for follow-up at the regional cancer hospital. The second lesion was also a very provocative lesion because of its location and size. And as you can see, it's a very big lesion, and the patient, we have tried to find the best optimal surgical decision here, planning, of course, firstly a triangular flap for this region. Then we have taken the decision to remove it with elliptical excision and then perform a deep undermining surgery, as you can see here. First of all, we have removed it in the muscle. The bigger area was closed with single stitches subcutaneous, and after that we have additionally performed electrocautery, so that we have received very good blood stoppage. And here undermining surgery in all directions, as you can see, in order to have the possibility to close the defect with a very small pressure. Here you can see after the defect was closed, and it is immediate postoperative defect, and it was a T2M0M0 BC clear resection line, so that with this lesion we were highly satisfied. Then we came for the last one. It was the most problematic one because of the regio infraorbitalis sinistra, which you know has some. Here could, of course, appear some complications when a tumor has to be surgically removed because of the ectropium on this area, which is very, very often. And then we have taken the decision to perform a malolabial advancement flap, and first to mark the surgical lines very carefully, and then to preserve the underlid, and with a very small surgical margin to excise all this. Here you can see in the right. Then we have taken the decision, here you see slowly undermining the tumor lesion under local anesthesia. Here you see in the middle of the surgery during the operation. Then we have already removed to the muzzle and stopped the bleeding with electrocautery and some stitches, and here you see the complete removal of this lesion. Then we have taken the decision to make a parallel incision near or parallel to the nasolabial fold, as you can see, a fast parallel, and then to remove this in direction underlid later. Here you see that we make a deep preparation of this tissue. At the same time, we have preserved the blood supply of this flap, and then remove it subsequently and fixed it with subcutaneous stitches, as you can see on image 2. After serious work, you see that we have done and performed a very nice adaptation of the subcutaneous stitches, and then we have performed a single very fine stitches, cutaneous stitches, single stitches with a good postoperative result. And then we have a stage 2 BCC, clear resection lines for our luck, and we were highly satisfied. Why we want to present the case? This is the most important. Nitrosogenesis of skin cancer is a modern concept in the medical literature, where we have already spoken about several times in our lectures, and that the link of the intake of nitrosamine-contaminated drugs and the subsequent development of different types of cancer, melanocytic and keratinocytic cancers, it is not a new thesis. It is a very famous thesis at the moment, and we know that the polycontamination of currently about 300 of the most globally distributed drugs with NDSRIs or nitrosamines has been since 2023 officially declared in the FDA recommendations to manufacturers, and the number of affected preparation is growing every day. The dilemma remains until now between the balance between the officially disclosed from the regulators to, of course, the hidden, not disclosed concentrations to patients, contamination data about these preparations. That's why we have taken the decision to perform some clinical studies in the last 7 years. And here you see that the clinical pathological correlations about especially melanoma and keratinocytic type of tumors like SCC or BCC after intake of potentially nitrosamine contaminated drugs suggest at least that elevated concentrations of nitrosamines presented in the polymedications might bear some serious problems for patients. Another issue is we know already here, as you can see, there are different informations. The updated. There are several updated things. First, furosemide, and then you have there are some recommended limits for especially independence of the carcinogenic ingredients in the drugs. And this table of the FDA is one of the most important data which we have at the moment. You know that Bisoprolol has the carcinogenic potency of 4 and furosemide of 4, and parallel intake during the last several years had led to the manifestation of several skin cancers. And we know that it is interesting that 4 is a very low carcinogenic potency. Here you see that these are NDSRIs assigned to category 4 may be metabolically activated through alpha hydroxylation pathway, but are predicted to be a low carcinogenic potency. For example, because of that, I have to share several points which seems to be important in the last times. They are not only metabolic activation. We think that probably some of these nitrosamines or nitrosamines related impurities be at the risk of phototoxicity, and this is a completely another way where we do not need an alpha hydroxylation for activation, and this is probably a directly developed phototoxicity and photocarcinogenicity, which is more important than this. It is noteworthy that, as already mentioned, concomitant intake of drugs with potential carcinogenic potency of 4 for a relatively short period could lead to the manifestation of 4 tumors. Here we have probably the other action, and here we have to discuss later the phototoxicity and photocarcinogenicity of these lesions. Polymedication, polycontamination might bear some serious risks. There are some papers about this. It is not only the one paper. Here you see a flavor of that, a very enigmatic paper of us. Perindopril-induced thick melanoma and BCC of the back. Here we have also the same problem. Perindopril is listed in the FDA list, and we have additionally BCC and melanomas in our case. We have also valsartan, BCC, and dysplastic nevi, similar like this dysplastic nevus and BCC after valsartan and hydrochlorothiazide. You know that both medications have been listed in the FDA lists. Here we have to look for, of course, later, is this performed probably via metabolic activation and alpha hydroxylation, or is this done via a completely another pathway of carcinogenicity, for example, genotoxicity or direct carcinogenicity. Here we have published another paper which confirms our thesis. It is sartans and cancer. Here we have multiple verrucous carcinomas and giant acral melanoma developing after therapy with valsartan and olmesartan. And otherwise, we have several series in the last year where thiazides and beta blocker again has led to skin cancer development and progression. Also, beta blockers in combination with sartans or ACE inhibitors also lead to this. And we have nitrosogenesis of cutaneous melanoma when we speak only about melanoma, thick melanoma of the breast in melanoma, and dysplastic mole after valsartan HCT. Here we have, of course, the probability and the possibility, if you want the thesis or hypothesis at the moment, that the contamination with NDSRIs could lead to could trigger phototoxicity, carcinogenicity, or mutagenicity and carcinogenicity. There are probably different pathways which has to be clarified in the coming years. Important papers, especially about when we talk about melanoma, is one of the last and latest papers from Imene Mansouri, important paper about the risk of contaminated with NDMA valsartan, and this article analyzes the risk about contamination with NDMA, where they have found a 10% risk in terms of melanoma development. It also remains an open question whether an analysis has been done of patients taking valsartan contaminated with other type of nitrosamines other than NDMA, and what was the rate of melanomas within that intake. To say that only valsartan contaminated melanomas has a risk of 10, you have to exclude it all other nitrosamines at least. In the paper, there are practically no data of melanomas occurring after intake of any type of nitrosamines. and we know there are about 200, 300 nitrosamines, probably many of them of valsartan. And such analysis has in all likelihood been carried out and at present remains, however, confidential due to the possibility that the percent of melanomas could jump enormously, of course it's a speculation, after the intake of not NDMA but other type of nitrosamine-related melanomas, valsartan. Otherwise, there is no way to declare that only NDMA monocontaminated valsartan has been studied. This is a personal opinion, of course. We know the two new papers which shed light on in last time on possible links. Here I have to add one N between Pharmaco-Oncogenesis, drug-related nitrosogenesis, and skin cancer development and progression. Some nitrosamines seems to be strong photocarcinogens, some nitrosamines have a mutagenic carcinogenic action in humans. These are very, very, very strong points because we have to look for another pathway, not the mutagenic and via hydroxylation in the body, but directly carcinogenic action and the photocarcinogenic action. This has to be clarified in the near future. This study has investigated the NMOR genotoxicity following UV irradiation without metabolic activation, and it has found out that it was directly mutagenic without UV metabolic activation in the AMIS test. And this is very, very interesting. The activity was very relatively stable, approximately 97% selectivity remained after 10 hours in storage, 37 temperature, and we see here that the volative NMOR may attach to environmental materials and be irradiated with UVA, and via air pollutants could float in the air on the human body and skin, and leading to genotoxicity. Even speculative, but it is of course very, very possible. The other problem is, are nitrosamines or tobacco-specific nitrosamines human carcinogens or human mutagens? Yes, the answer is yes. They could be, as known till now, they could be first mutagens without carcinogens, they can be mutagens and later carcinogens, and they could be directly carcinogens. When we speak about tobacco-specific nitrosamines, we know that some of them are potent carcinogens that cause mutations and critical genes in human DNA where they have critical target genes as RAS-oncogenes and P53, and these are their targets. And our study seems to be indicative that the possible contamination in furosemide and bisoprolol with nitrosamines could be at the risk for cofactor for development multiple keratinocyte cancer and cutaneous melanoma. Here I have to mention once more that RAS-oncogenes and P53, these are the major genes which are affected also in melanoma and non-melanoma skin cancer, so that we have a great overlapping between the nitrosamine-induced mutations in genes, which are also responsible for the development and progression of cutaneous melanoma and keratinocyte cancer. When this is not an direct or indirect evidence, I don't know. Nitrosogenesis and Pharmaco-Oncogenesis of skin cancer seems to be reality and not a myth. Short-term intake of these potentially contaminated drugs poses or is associated with a short-term risk of developing keratinocyte cancer and melanoma. We have to find a way. Is it this via metabolic activation, or is it this via directly carcinogenic action or the photocarcinogenic action? Future analysis would be revealing as whatever the degree of elevation of nitrosamines above the FDA determined limits, and or the concurrent intake of a heterogeneous class of carcinogens in antihypertensive polymedication, but not only, has a role as co-stimulator in the development and progression of skin cancer in general, or perhaps probably both. So that here, the lack of officialization of the concentration of certain carcinogenic constituents in medicine suggests, albeit indirectly, that nitrosamines are a serious problem or probable proteogenetic factor. The fact that this a substantial number of international clinical follow-up studies, past and present, have also linked some of the most commonly distributed potentially nitrosamine-contaminated drugs to the subsequent development of skin cancer is indicative for this possible relationship. New classes of potentially or actually contaminated products such as bisoprolol or furosemide are able to lift the veil of concerning the so-called photonitrosogenesis and carcinogenesis or oncopharmacogenesis, new terms in medicine which are related to skin cancer's pathogenesis. Differences in the results of these follow-ups worldwide could be due to the sporadic or controlled contamination in certain geographical regions. The fact that manufacturers can accurately classify between contaminated and non-contaminated production and have geographical areas clear of any contamination is indicative that contamination can be controlled and easily clarified. Photonitrosogenesis of skin cancer remains no more a hidden truth and at the same time controllable process. Drug-related nitrosogenesis is essential part of the oncopharmacogenesis or skin cancer pathogenesis. Economically profitable production areas such as China and India should be subject to a serious analysis in terms of potential risky production that should be eliminated in short term and permanently. Until then, analysis regarding nitrosamines could be considered as priority with a view to clarifying even more clearly their role as at least cofactor for skin cancer in general. We have had the possibility to publish this nice paper in Georgian Medical News, a great journal which has agreed to publicate another thesis, another viewpoint for the skin cancer's pathogenesis, which probably in the near or not so near future will contribute to the completely resolving the dilemma of skin cancer, but not only of skin cancer's pathogenesis. Thank you for your attention.